Thank you, everyone, for your kind words. It needs to be introduction, but I recollect the good old days that we shared at All India Institute when the both of us were there. And indeed, my deep gratitude and thanks goes to the entire team of the Howrah branch of the Indian Society of Critical Care Medicine, who have taken the endeavor to organize this work with this CAB, in particular in concurrence with their newly gained recognition of from the ISCCM National as a branch, independent branch, as a distinct branch. So my best wishes goes to each and every member of the branch, and I also congratulate for collectively, unitedly earning this stature by a lot of hard work. So we were since this is a very thematic evening, the CAB in today's evening, and that pertains to one of the areas which is not often recognized or which is often understood with lesser pertinence in the context of critical ill patients, in the care and in the nurturing of critical care patients at critical times when probably a lot more difference can be made and a lot more changes in the outcome can occur if proper care and proper intervention is exercised with the due honesty. Can I have my slides, please? Yeah. So I want to remind you that in 1940s, 39-40, that was the time when people were celebrating the invent of penicillin. At that time, one gentleman whose name was Ernst Boris Chain, you can Google and find out. He was a biochemist who made a contrary claim that, well, today this is working, but there is something called penicillinase which is going to affect it and it will become a defunct antibiotic very soon. But nobody paid heed to his words, but he made some noise. And some people heard, but eventually that happened because he was the first person who, even just within a year or so after the launch of penicillin, Ernst Boris Chain had made a claim that all these effects of antibiotics will be short-lived. So there were more of opponents to his concept those days. But later on, gradually we remembered when we identified the penicillin binding proteins and followed by the identification of the ESBLs, then that came naturally. It did not require much of explanation for it to do. So similarly, when today we talk about antibiotic stewardship, when we talk about fluid stewardship, we fail to understand that unless this stewardship is done in a comprehensive manner such that each and every component gets its due importance, the entire stewardship program will achieve very little success. So, a stewardship to only antibiotics is not going to fetch an overall improvement in the outcome of critical care in terms of mortality, length of stay, etc., etc. But if all these stewardships are combined and they are attended to in a way in which they deserve to be attended, then probably a lot of changes, a lot of benefits can be accrued at the earliest without facing the adverse effects or other disadvantages. Now, if we just go through, so this definition had come up in 2012, that what is this nutrition stewardship? It is an ongoing effort by Healthcare Institute to optimize artificial nutrition. So this optimization of artificial nutrition is something very strongly demanded by the concept of nutritional stewardship, and neither it should be in excess nor there should be any deficiency in order to improve patient outcomes. Patient outcomes, although we primarily consider mortality as an outcome, but besides mortality, there are a lot of other outcomes which are also very important for us intensively, particularly the length of stay in the ICU. Ensuring cost-effective therapy and reduce the adverse sequelae. Many a times, a lot of adverse events takes place which are not recognized only. Forget the time that is incorporated in the data and the data is subsequently audited to find out. But many a times, a lot of the minor adverse effects gets unrecognized. Now, it is also to reduce the adverse sequelae, and it focuses on nutritional assessment of the critically ill patient, the route of the nutritional support that is to be appropriate for the patient at that stage of the illness, the access to the nutrition, because that depends upon the providers of the nutritional therapy, that who is actually providing, whether he or she has access to that or not. Fluid and electrolyte issues, because a lot of time we know that the fluid and electrolyte issues, fluid creeping is such a common problem in sepsis. So a lot of time, whenever the fluid and electrolyte issues are there, the effects of nutritional supplementation cannot be conceived. We all know that metabolic alkalosis goes so hand in glove with hypoalbuminemia, but still, a lot of time the fluid and electrolyte issues, because this is the extracellular compartment where the fluids and the electrolytes tend to accumulate in a critically ill patient who is having a systemic inflammation, and that is also where the chances of accumulation and dilution of the supplements can occur. Specialty enteral products, because many of those enteral products are incompletely absorbed in critically ill patients, and whatever is expected in a less sicker patients cannot be expected in a more sick patients. And optimal blood glucose control, because glucose is an osmotically active particle which draws in water from the other compartments, and wherever the blood glucose level is elevated, it indirectly influences the availability or the bioavailability of the other drugs. So the main goal here is to attenuate the development of malnutrition, because if a patient is malnourished, his chances of responding to the antibiotics, to the other specific drugs for the illness, is much lesser in comparison in who is adequately nourished. And that is where the role of antimicrobial, this nutritional stewardship achieves its importance, that it assures that this antimicrobial stewardship, the fluid stewardship, actually sees the light of the day, achieves a good result. So this is the potential mechanism of the nutrient-drug interaction. We know that the drug-drug interaction always takes place in the consequence of any co-administered agents, particularly in a patient with polypharmacy. But when a nutrient is there, that nutrient may be protein, that nutrient may be amino acid, that nutrient may be magnesium, whatever. But this will all follow the stages of ingestion, where the drugs and they can actually antagonize each other, or they change each other's level. Then followed by the stage of absorption, where if certain drugs adheres or absorbs to the mucosal surface, it can limit the absorption of the nutrient. The gastrointestinal transport, because the carrier proteins are very important, and when identical carrier proteins exist for the drug and the nutrient, that can minimize one's transport to the tissues. Metabolism, because most of the drugs are metabolized either in the liver or in the kidneys, either in a metabolically active form or in an unchanged form and excreted in the urine, and there may be a competition if particularly the enzyme system or the cytochrome 450 is involved. Distribution, because the distribution is affected by the volume of distribution. We all know that when the volume of drugs which have a high volume of distribution tend to stay less in the plasma, which have a low volume of distribution tend to stay more in the plasma. So if we have organism growing in the blood, for a common instant, which is sensitive to both colistin and tigecycline, we prefer colistin because it has a low volume of distribution, it stays in the plasma, and tigecycline when it has a high volume of distribution when the drug resistant bugs is elsewhere. Now the same applicability of the same concept is also there in the nutrients, because the distribution is also follows the path in which the volume is distributed or the water is distributed. And of course the elimination, because in the elimination, if there is a competition between the nutrient and the other drug, then one of the two can be retained, in which case either there can be toxicities because of the existence of the or retention of the nutrient, or there can be a toxicity because of the drug. So this phase, which is pertinent for drug-drug interaction, is equally pertinent for drug-nutrient interaction, and every clinician should have some idea about this nutrient in relation to the co-administered drugs to maximize the chances of benefit for both the drug as well as for the nutrient. So what are the essential elements of this nutritional stewardship program? One is that we should follow the international guidelines. Currently we have 4 international clinical practice guidelines, and all these guidelines are available, whether it is ESPEN, whether it is ASPEN, so all of the German society, so all of these are available, and we can choose, of which the latest one is the ESPEN guidelines of 2019. Guidelines should be adapted to the local context. Whether those guidelines can be applied directly on our patients or not, that is an individual decision that we have to take, considering the PKPD, considering the patient profile, considering the body habitus and so many other morphological features, and adaptation to the local circumstances with input from senior clinicians can increase the acceptance rate of this nutritional stewardship program rather than for trying to follow blindly any other guideline. And prescription approval with post-prescription review and feedback. This is very important because in our country, most of the time, these products are prescribed by the clinicians who are seeing the patients, whether he is a physician, pulmonologist, intensive care physician, internal medicine, or so on. In many places, other where it requires a concomitant approval from the nutritionist, the clinical nutritionist. We don't have this practice. So what this says that prescription approval with post-prescription review and feedback should be obtained to make it a successful nutritional stewardship program. This element is also very important. Now, as we know that there is a 6D framework for antibiotic stewardship, there is a 6D framework for fluid stewardship, there is also a 6D framework for nutritional stewardship. The first D for diagnosis, identifying the patients at risk of malnutrition. These are the patients who would get the maximum benefit if the nutritional therapy started at the earliest. Then the drug, because every nutrient should be considered as a drug for the same reason for which it has been found to have a drug-nutrient interaction, and it should present a different quantity of calories, different content of nitrogen, protein, glucose, lipid, micronutrients, and therefore the component and the consistency of the product will also matter while its selection. The dose, choosing the right dose by taking into account the PKPD in the same way that we take into account the PKPD of a drug, and the volume kinetics. The duration, like for antibiotics, we want to for early de-escalation. So similarly, here in nutritional stewardship also, the duration is important, particularly when the patient becomes capable of taking the nutrition or amalgamating nutrition from other natural route, that it can be terminated or discontinued. De-escalation, that is gradually moving from parenteral to enteral and then to complete cessation. And discharge. This is something important because at many a times it is often ignored that at the time of discharge, not so much of attention is paid into the nutritional recovery of the patient as much is paid to the recovery from the illness for which the patient is suffering, and it is expected that once the illness is cured, the nutritional recovery is automatic. But probably that leaves a scar for which it may be delayed. So in case of such delay, the recognition of such patients where there can be a delay in the nutritional recovery, that needs to be identified and accordingly treated. So performance measures are also important in any nutritional stewardship by minimum standards of monitoring, therapeutic streamlining, outcome measures, cost effectiveness, and this should have concordance of prescription with the institutional guidelines in an indication-driven protocol. So every institution is free to design, but the source or the origin, or that should be some recognized, accepted guidelines which is followed, and if that forms the basis of the framework based upon which the institution derives its protocol or frames its protocol, the chances of success with the nutritional production or the stewardship program is maximum. The chances of benefit that can be accrued in the patient will be maximum, and the chances of adverse events or failure to motivation will be minimum. So the ongoing benefit of a nutritional stewardship must be demonstrated to the hospital management group, because in many of the times the hospital management decides or determines the quantity or extent to which such programs should be supported, or whether those products which are necessary to support such a program should be made available to the hospital. Now, once we have these indicators, it will be easy to convince the hospital management about their benefits, about their utility, and for further modifications if required at any point of time. Now, I am going to show you certain very good findings from certain studies. Nutrition therapy in intensive care unit setting, what can be learned just by doing a 6-month survey, so in a large hospital, so in which 426 patients in the ICUs were collected. A multivariate logistic regression was performed to identify the predictors of enteral and parenteral nutrition within 48 hours of admission to the ICU. So irrespective of the fact that whether the patient is very sick in the Apache or in the sofa, or whether the patient is expected to be in the ICU for less than 72 hours or 96 hours, and the relation between medical nutrition therapy, mortality, length of stay, and these were evaluated, where you can see the odds ratio, and you see that nutritional screening and energy needs determining processes has a very big room for improvement even in such countries where nutritional stewardship program existed for the last 10 years. So what the patients were given prompt parenteral and enteral nutrition in only 1/4 or little more than 1/4 of the patients, and predictors of early enteral nutrition were type of admission and surgery before admission. Early parenteral nutrition predictors were gender, ICU, and central venous catheter presence. Why it is important? A lot of time nutrition supplementations escapes notice because the patient does not have a CDC line. So this was one of the factors which identified what are the predictors of early institution of early care. So the need for monitoring clinical nutrition prescribing behaviors and patterns in acute hospitals ICU to better set up tailored interventions, because we all know today what one thing, if we know at all one thing, that totally one size fits all strategy does not work in nutritional therapy as much as in for any other therapy, and therefore a tailored treatment is necessary, which is a very complex, which is very difficult, and to achieve that a lot of hard work needs to be put. This is again, it was published in Critical Care Medicine. The energy deficit and length of hospital stay can be reduced by a 2-step quality improvement of nutrition therapy, and the intensive care unit dietitian can make the difference. So it is a very good study which points that sometimes intensive care unit dietitian or the nutrition is not considered as a very important person by us, but their intervention, their presence and their involvement in such program can make a lot of difference in the overall outcome. So a bottom-up protocol improved nutritional support. The presence of intensive care unit dietitian provided significant additional progression which were related to early introduction and route of feeding, and which achieved overall better early energy balance. So clean-cut proven that their participation can make a big difference. Oral nutrition during and after critical illness. So this is something which is often debated, because how can the oral route be considered as a good route in a sick patient, but it has said that we have to take care of the spices. This is an acronym basically, which takes into consideration the swallowing disorders screening management. P for patient global status overweight, the involvement of dietitians. C for clinical improvement of nutritional index and outcomes, and finally supplementation in the macro or micronutrients. So this is again a very important item which compare all the different the ingredients of nutrition stepwise manner with the guidelines, and try to find out that whether how the different recommendations of the different guidelines can give a common shape in this program. Now, in order to achieve the best benefits, it is important to tailor all these different aspects to meet the patient's needs in view of the basic principles that every ICU patient is at risk. Regular screening for malnutrition, close monitoring and frequent adaptation of the nutrition. If a patient is prescribed one particular mode of nutrition, that may not be enough for that patient for the entire duration of ICU stay. Micronutrients are mandatory if parenteral nutrition is necessary, and individual adaptation to the nutrition which he or she is prescribed, and to monitoring them in a wholesome manner. To end, I want the take-home message should be: critically ill patients require rapid, effective and complete nutritional support management. Nutrition in critically ill, not one size fits all. If selenium is there, it should not be that selenium or glutamine or arginine or anything of that kind can be administered to each and every patient, or if the patient fulfills one or two set norms. A multimodal intervention for an optimal nutrition therapy should be provided during critical illness, after ICU discharge and even after hospital discharge. The cornerstone of nutritional stewardship program is the implementation of the institutional guidelines that can be framed with the framework of one of the recommended guidelines, which should largely accord with the international or national standards, augmented by audit and feedback, the quality use of medicine indicators and the performance measures. Thank you very much for your patient hearing, and I once again thank for their active participation in this program. And also my thanks goes to Mr. Prabhakaran, who has taken this initiative to support this program. Thank you very much.